Welcome to Healthy Focus, the Duke Raleigh Hospital Community Education Series.
Please join me in welcoming Dr. Karl Schweitzer.
Thank you, Mandy. I appreciate it. Appreciate everybody coming out tonight. I know everybody has a lot of things to do, so we'll definitely respect your time and leave a fair amount of time at the end for some questions or anything that comes up. We always have to have disclosures. I had none. I'm early in my career. No one is paying me to say anything. I have no disclosures except that I'm very passionate about foot and ankle surgery and I love what I do. So tonight's goals, we're trying to improve your awareness of the major issues at play with patients that suffer from ankle arthritis and to understand how the nature of this disease and its demographics or the types of patients that get it, how all that impacts how we treat it. As a spoiler alert, as one of my fellowship mentors said to me early last year, he said, "Karl, this ain't your grandma's arthritis." So to begin, so ankle arthritis, it's not life-threatening like cancer or heart disease or even kidney failure, and all those topics have been discussed here in prior Healthy Focus talks. But we do know that ankle arthritis can be a very painful condition, can become very functionally limiting for the patients that suffer with it, and can become very debilitating as well. And ultimately, for the patients that have it, it really just becomes a quality of life issue. So there's one fact is that over 2 million people come to their physician, not just orthopedists, but primary care, with complaints of ankle pain from arthritis or even fracture. And so we see a lot of this. Certainly not as common as hip or knee arthritis, as we'll outline, but this is generally what we see when we're talking about ankle arthritis. And so this is a patient who had a prior fracture, broke this bone and broke this bone here. It's healed well, but as you can see, and we'll show you some normal ankles, you can't really see the cartilage that well, and the cartilage is usually the black areas there. And so the joint is collapsed just like it is here. So we're getting excited, but we're going to put down our scalpel for a second so we can talk to the patient. I always try to find out what their story is. With ankle arthritis, it usually comes down to some type of injury or chronic recurring process, whether it's instability or just multiple injuries to that ankle. I like to try to find out what treatments they've tried for it and ultimately how it's affecting their quality of life, because I always tell the patient they're in the driver's seat with this. If they have x-rays like that and it doesn't hurt, then there's not much I can do to make them any better. So we try to find out what is keeping them from doing that they like to do and ultimately find out what their goals. And we, over multiple visits, talk about all their options. So it could be something as simple as adding an anti-inflammatory or an ankle brace or even an occasional ankle corticosteroid injection. It could just be modifying their activities. Maybe they were a runner and maybe now that's not going to be a possibility for them, but maybe they can get the same exercise with swimming or an elliptical machine. Or maybe they need more of a custom brace if they have more deformity. Or maybe they've just been dealing with this for 5 or 10 years and they're just sick of it and they want to talk about some of the surgical options. Down there on the left is an ankle replacement, and on the right, in the middle, is an ankle fusion. Well, let's have a closer look at it. This is the see no evil from see no evil, hear no evil, speak no evil, but the next slide is a cadaveric dissection, so for anyone that gets a little light of stomach, just look away for a second. I think it's actually pretty beautiful anatomy. So this is what the actual ankle looks like, and these dissections are all done by the late Paul Galano, who actually came and, along with Dr. Nunley, during my last year of residency, came over from Barcelona, Spain, and did dissections with us as part of kind of our thesis. And so his favorite thing to talk about was the ankle, and so I love that. And these are some of his dissections, and you can start to see some of the anatomy of the ankle here. This is the joint we're talking about here, and you can see nice cartilage, and this is all cartilage surface here, as well as up and around here. Now this bone here is the tibia, and this is the talus. You'll hear the ankle joint called the tibio-talar joint, or just the ankle joint, and you'll hear the joint described as a mortise. So you have this kind of wedge-shaped, and that creates a lot of stability for the ankle, which is important. Probably most important for stability, besides how the ankle was just built, are all the ligaments. So this is the ankle from the front. This is seeing the ankle from the back. and this is kind of looking at it from the side, and you can see along every aspect there's ligaments that are holding this together. So here, these are the most common ligaments we tear with an ankle sprain. Here is up in this region here between your fibula and your tibia. You've heard of a high ankle sprain, which a lot of basketball players or football players get. That's the area of a high ankle sprain, and this is the syndesmosis, or the area of a high ankle sprain seen from the back. And these are some of the ligaments that stabilize the ankle from the back as well. Well, orthopedics is a lot like mechanics and carpentry, and you can see the ankle is really, it's nothing new. It's similar to a mortise and tenon design of how you almost build furniture. So it's a very stable kind of construct, and then the ligaments just add to that. The muscles themselves, the tendons, provide some dynamic stability to the ankle. But also what makes the ankle very stable is, if you look at it from the top, and this is the talus bone, so these would be your toes out here, and this is your heel bone back here. The talus is shaped like a trapezoid, so that when the talus comes up in the ankle, it increases its stability as well, and that helps with stability with motion. And this was a study that was done in the 1970s. People still talk about it at every conference we go to, and it's a simple thing that they found out, that a 1 millimeter shift in the talus and how it sits in the ankle joint decreases the contact area for the joint, so how the cartilage opposes each other at the tibia and the talus. It decreases that by almost 40 to 50%, which is huge because the ankle is already a small joint. It has about 1/3 the surface area of the hip or the knee. And so here is a x-ray seen from the front of an ankle fracture. So here the fibula is broken here, and it's a common pattern, and it's an unstable pattern because here you can tell things are a little bit wider here than they are here, and this should all be the same distance here. And so the talus has shifted that way towards the fibula, and you can tell if you don't fix that or restore the normal anatomy, that's going to be a problem down the line because of that fact right there. So if we look at the foot and ankle and the normal motion, I think we all know that the ankle kind of moves just up and down in simplest terms. So we say up, we talk about dorsiflexion, and when it moves down, like when you push off and you're walking or running, that's plantar flexion. In the other plane, you start to see the interplay between the ankle joint and the joint that's below that. So there's a joint below the ankle, and that's called the subtalar joint, or the joint that's below the talus. And that's the joint that really allows you to walk on uneven ground, allows you to have that side-to-side motion. And when you have arthritis in your subtalar joint, you really notice it when you're trying to walk on like a cobblestone pathway or uneven ground or uneven surface. The fact is that these two joints have a lot of interplay together. So if you have arthritis of one, you start to get some almost uncoordination between the two. So if you look at normal range of motion, your ankle can pull up about 20 degrees from neutral, which would be 90 degrees, and it can go down about twice that, at about 50 degrees. The hindfoot, or the heel bone, can turn in and turn out through a range of about 15 degrees. So that's that side-to-side motion at the back of your foot. And certainly subtalar motion is very complex and has detailed anatomy. But I think you really just have to consider the ankle and the subtalar joint kind of together, because ultimately that's what allows you to navigate a surface like that, or even try to get over that pile of rocks over there. Because ultimately the two joints kind of function as what they call a mitered hinge. And it basically, if you think of this as your leg bone here in your foot, it changes the rotation or transfers the force from your leg to your foot, which is a very important for gait and normal function. So kind of back to the topic at hand, we kind of diverged a little bit. We'll get back into some ankle arthritis, and there's three main types that we're going to talk about. I've put in large font what's most common, and that's probably about 80% of the ankle arthritis that we see in clinic, and that's post-traumatic. And what does that mean? So that's an arthritis that came from a fracture or recurrent sprains, and even if you fix the fracture and make it look perfect on the x-ray, there's still injury to the joint at the time of the trauma. So when they fell off their bike and twisted their ankle and broke it, and the surgeon put it together the very next day and it looked great, there's still injury to the cartilage that can come into play years down the line, and that's what we call post-traumatic arthritis. There's also inflammatory arthritis, or you might hear it as rheumatoid arthritis, or even gout sometimes. That's certainly a lot less common, and then even less common than that is what we call primary arthritis, and that's what everyone thinks of when they think of arthritis in their hips and their knees. That's just the normal kind of wear and tear arthritis that you get, not from any specific injury or break or fracture, but just kind of the natural process of aging. And with that, you get that loss of cartilage, you get these osteophytes or bone spurs that form on the sides and fronts of the joint. You get some cysts in the bone that borders the joints as a reaction to the arthritis. And you get what they call sclerosis, or almost hardening of the bone. And that's when people talk about kind of bone-on-bone arthritis. So this is a look at primary arthritis like we're talking about. And you can see it's very white around this joint. And that's because the bone's hardened from all the arthritis that's occurred. You don't even see the cartilage. And you can see the spurs that sit on the front up here, and even some in the back as well. What's kind of confusing, that ankle arthritis isn't really like hip or knee arthritis, because really in the ankle, this primary arthritis that occurs so commonly in the hip or knee is so rare in the ankle, and it doesn't make a whole lot of sense. We do know that ankle arthritis is about 9-fold less common than it is than primary arthritis is in the hip or the knee. So certainly I'm not seeing as much arthritis of the ankle as the folks that are taking care of all the hip and knee arthritis. You do know that the ankle joint, because it's where it's positioned and withstands all the weight of the body, that it's subjected to certainly more weight-bearing forces and certainly more injury than really any other joint in the body. So one would wonder why it doesn't develop more primary arthritis. The ankle, as I said, has about 1/3 the surface area, so if it's a smaller surface area, you would think there'd be more force there. And the cartilage on the ankle joint, is, when we showed the dissections, I mean, it's really only 1 to 2 millimeters thick on either side. We know in the knee from dissections that it's 2 to 3 times as thick as that. So it really just appears that the cartilage of the ankle is just more resilient to getting primary arthritis, and so often it takes a fracture or recurrent instability or multiple sprains to get the arthritis that we're seeing. This is inflammatory arthritis, and what's common with that, so this is a rheumatoid arthritis patient, not only do they tend to get arthritis in the ankle, they get it in the bordering joints as well. So the joint out here, where the talus comes to meet the navicular, and they have some arthritis in the joint below the ankle, or the subtalar joint. And this is what we're going to mostly be talking about tonight, and this is post-traumatic arthritis. So this patient, I've drawn some lines on here to show that things aren't lined up like God made them. So on the left there, you can tell that at some point that patient had a tibia fracture, and maybe it was treated in a cast, or it maybe just healed with a little bit of curvature. It also had healed a little bit of curvature on the side view as well. And then even though it was fixed, sometimes you still get a step off there of the joint, and those are screws that are used to fix that fracture of the tibia. This is also post-traumatic arthritis, but this is kind of a different animal. This is arthritis that started in a lady that had a flat foot, and her flat foot was so severe that it wore out the ligaments on this side of her ankle, her deltoid ligaments, and when that gave way, it let the talus tilt in the ankle, like you see here, and so this wears a lot more than this area. And I've drawn the lines there to show you how the talus, or the bottom bone in the ankle, is sitting actually in the joint itself. In fact, she fell over so much into what we call valgus, or outward tilt, that she actually had stress fractures. That's the yellow arrow up there. She had stress fractures of her fibula because they were seeing so much force on the outside of her ankle. So this is certainly a bad problem, and those don't look like fun feet to walk on. This is more post-traumatic arthritis, and this is just to show some of the issues that come up with this particular type of arthritis that we see that some of the other folks that treat the larger joints don't see. These ankles come often with a lot of hardware. They were fixed 20 years ago, and so there's hardware in place. They have multiple incisions already. A lot of these patients have had 5 or 6 surgeries already. and they come sometimes with large, this is a big bone cyst here, and that's just because of how the talus is wearing away the tibia, and so you get all these reactive changes, and so the problems are a little bit different with foot and ankle arthritis. This is arthritis from what we call chronic ankle instability. So this is where the ligaments on the outside, this is your common low ankle sprain or ankle sprain that you hear about or that you had on your way to the grocery store, where the ligaments that insert here have pulled off, and you can see even here, so the ligaments pulled off with a small piece of bone. And over time, most ankle sprains will heal, but sometimes, if you've had so many of them, your ankle will start to tilt, and you can develop uneven wear and arthritis. And so that's another problem. So why are we going and boring you with all these details of ankle arthritis? You're asking yourself, isn't all arthritis the same anyway, despite what he's saying? My mother has bad arthritis, and now I'm starting to get some now too. Well, the differences between ankle arthritis and other more common forms of arthritis, the hip and knee, they're not always as obvious as this headline was in a local newspaper that fish need water. So why are the demographics important? So this is your typical ankle arthritis patient. Notice his age range compared to the normal knee arthritis patient. Very flexible, active. So if you look at knee arthritis, like I'm saying, most of the arthritis with that is primary or osteoarthritis. And those patients present usually in their 60s or even later, sometimes their 70s or 80s. They come with a family history of arthritis. 85% have other comorbidities, so by that point in your life you're starting to develop some diabetes or heart disease. And these other forms of arthritis that we see a little more commonly in the ankle aren't as prominent. And so we don't see a lot of traumatic arthritis in the knee like we do in the ankle. So this is a table, not to confuse you, but it's just some data on ankle arthritis that was collected at a Midwestern hospital. And it really just shows two important observations. The first is that the majority are from prior trauma. So if you look here, this is percentages, so 70% is post-traumatic. These other entities, primary arthritis, gout, neuropathic arthritis, osteonecrosis, which is, you've heard of it in the hip, where the bone almost dies and collapses. That's very rare in the ankle, and rheumatoid makes up a little bit larger percentage. The other thing to look at is really the average age of these patients in this population. They're nearly a decade younger than the hip and knee arthritis that we were talking about. These folks are 51 on average, and so that's almost a decade younger, which means a lot when you're trying to treat someone and know that they have 40 or 50 life years ahead of them, and you're trying to give them one surgery. This is if you break the ankle arthritis group up, you can see that most, in fact, are from prior fractures, rotational injuries, ligamentous injuries, instability, sprains. That's kind of what we're talking about with ankle arthritis. So if you expand this data back out to include hip and knee arthritis listed on the top columns there, you can see really that primary arthritis makes up the vast majority of arthritis at the knee and the hip, and here at the ankle it's post-traumatic. So you're starting to get the idea. So just to summarize the last couple of slides, this is not your standard hip and knee patient. The demographics are different. Mainly it's post-traumatic arthritis, and these folks come with deformity like we saw before. They come with scars from multiple prior surgeries. They come with hardware in place, which can complicate any future procedure that you may want to do. And they come with neuropathy, and that can mean pain at nighttime, or it can mean numbness, or just funny feelings in their feet and their ankles. They're certainly younger, about a decade. They're more active. These folks are trying to work. I mean, they're oftentimes in their most productive stage of their life in terms of family and career responsibilities, and oftentimes they're just miserable. So what's the problem? Well, we know it hurts a lot, and it impairs their function and quality of life. And here's an important study that was put out in a rheumatology journal that really showed that patients' self-reported physical function, those with ankle arthritis, were at least equivalent or worse to the patients that had end-stage kidney disease, so patients that are on dialysis, or patients with severe heart failure, or even really bad neck pain. So that kind of just drives home the point of how much this impacts people's lives when they're younger. And so what's the solution? Well, there's many here, and I've listed as many as I could think of, and as many as what I talk to patients about when they come to clinic. And so one of the obvious things is just to modify your activities. So maybe you're not going to be a runner for the rest of your life. Maybe you need to start thinking about cross-training or doing other less impactful exercises. Maybe weight loss might help to decrease forces on your ankle. Sometimes you can add a rocker to the bottom of a shoe. You've seen the Skechers shoes that can simulate what your ankle tries to do and offload the ankle joint. If you can change someone's level of pain and symptoms and improve their function with the shoe, I mean, that's so much better than any surgery that I could ever offer a patient. Sometimes, if it's appropriate, we can add an assist device to help with their gait, such as a cane. Sometimes we can just help out with an ankle brace. That could be something you get at Walgreens or something more custom if you have a little bit more deformity or angulation to your ankle. You can add some anti-inflammatories, just like your hip and knee arthritis. You can add some supplementation. And sometimes an occasional corticosteroid injection can be quite helpful in terms of pain relief for these folks. When we're talking about surgery, I've tried to list out some of the basic ones that we think of. You've all heard of arthroscopy, where you put cameras in joints and then put small tools and you can debride painful areas and synovitis or inflammation of the joint lining. You can even take off painful spurs that are on the joint. And we know that for focal lesions or for focal arthritis, this works reasonably well. But for folks that have the x-rays that I've been showing, we know that that may help on the short term, but they're going to be right back in your clinic and they're going to be hurting just the same. So you need to be mindful of that. I put on here osteotomy, and that just means we break the bones. And so if you come in with an ankle that's not sitting like this and it's more like that, and you don't have a lot of arthritis, there's literature out there to suggest that if we make your ankle more normal and align it perpendicular to the ground, that really we can offload those areas of bad cartilage that have developed and put the stress onto the areas of cartilage that are thicker and can bear more of those forces. There's other things that we're not going to really get into that are really just more custom type procedures that come about very rarely. And I think the two that we'll focus on for the rest of the talk are the two that probably gain the most publicity and that you've heard about, or maybe some of you even have, or have family members that have had either an ankle fusion, or they call it an arthrodesis, where you take away the joint motion and fuse those tibia and talus bones together, or an ankle replacement or a joint replacement. So you've heard of an ankle fusion, but maybe you're not quite sure what it is. So why would you fuse someone's ankle? Well, it can basically take away the limited painful motion that's already there and create a very stable construct to walk on. And you can do this with an open incision, or you can even do it with the camera. If there's not a lot of malalignment and the joints are reasonably well aligned, you can go in there and actually do it arthroscopically. And so the idea is that you just remove any remaining cartilage that's in place. You then realign the joint if it needs it, which is usually easily done. And then you just prepare the two ends of the bone so they can grow together. And what that usually means is you drill holes in them. You want to stimulate healing so that those two bones literally knit together and create a stable ankle. And then you want to fix and kind of compress the joint so that the body can heal it, which at a minimum would take about 6 to 8 weeks. And this is showing a fusion here. You can do it many ways. You can put a plate across the front of the ankle and a screw from the back, or you can just use multiple screws at different angles. They all accomplish the same thing. So what's the 411 on fusion? Well, we know that it's tried and true, it's predictable. It was described literally 130 years ago in the literature, and it's long been considered the gold standard for treatment of ankle arthritis. We know it provides good pain relief, and it eliminates that painful motion that we're talking about. Patients are generally satisfied with it. It provides a stable foot to walk on. For our younger patients or our heavy laborers, so the 30-year-old with ankle arthritis who had a bad injury when he was 15, he can really tell him he can go hard on it. And really, after it heals, there's really no restrictions that I'd put on him. And historically, we've seen fewer devastating complications surgically compared to ankle replacement. So why would you ever consider anything else in a fusion? Why would anyone even try to design an ankle replacement if all these good things are true about fusion? Well, for a fusion, the recovery process can be longer. And what I mean by that is that we usually keep the patients off of it for about 6 weeks at a minimum. So that means no walking for the first 6 weeks. You're either in a splint or a cast or a protective boot. And we know that over time, from what people have published on their results, that 1 in 10 or 10% don't heal or don't fuse. And sometimes if that's painful, then that can require more surgery. We know that a fusion is not natural. It's not what most people were born with, and so it alters your gait a little bit. Some folks, you can hardly even tell that they've had an ankle fusion, but if you put sensors on them and looked at them in the lab, you'd be able to tell subtle differences in their gait or their stride, in the amount of motion in their other joints. We know that patients with ankle fusions can have some functional limitations, so walking on uneven ground or going up and down inclines and stairs. We know that if you stiffen the ankle by fusing it, you can cause some increased wear and stress at the joints that border it. So this is a classic example here. Patient has an ankle fusion that's healed and looks in great position, but unfortunately they developed arthritis at the bordering joints because the ankle is used to moving and you stiffen it, and over a process of 15 to 20 years, or sometimes shorter, you can develop arthritis of the joints around it because now these are trying to provide the motion that this joint once did. So you can imagine that can cause a problem. And we know that about 7 years after an ankle fusion, about 50% of folks will have some sign, at least on x-ray, of arthritis of those bordering joints. Now that's not to say that all those patients have symptoms, but you can at least see this process starting on a radiograph. And we have some sort of inherent knowledge or bias to think that somehow a pain-free mobile joint is somehow better than a pain-free fused joint. It just kind of makes sense. It's what we were born with. And so we enter ankle replacement into the discussion. And so you recognize the downsides of an ankle fusion. It's not a perfect procedure, but neither is any surgery, and neither is an ankle replacement. And so we're often asked the question, what do we do with the patient who develops pain and arthritis at those nearby joints? That's a tough situation to be in if those joints are symptomatic or hurt the patient.